We'll start now because now 7:15 p.m. now. So I am Dr. Saminda Paranahewa, consultant ophthalmologist at Teaching Hospital Kurunegala. Good evening, everyone. So today our topic is ocular trauma and ocular emergencies. So why we need to talk about this topic is, because we need to understand what is ocular trauma and emergencies, and we need to recognize and we need to act fast to prevent the further damage and the blindness. Because of that, it's important to understand and recognize the ocular trauma and emergencies and respond quickly. So when we're talking about the definition, ocular emergencies refer to urgent medical conditions involving the eyes that require immediate attention. So any medical condition which we need immediate attention to prevent vision loss and other complications, which we call the ocular emergencies. So, importance of this is the timely intervention is crucial because it and those conditions can further damage the eye, and the eventually patient can lose the vision. Because of that, if we intervene timely, so we can prevent permanent damage and we can preserve the vision. Because of that, it's very important to identify and recognize, and we can act timely. So objectives of this lecture are the raise the awareness of ocular emergencies and trauma, and recognize their signs and symptoms, and understand the appropriate response to these emergencies. So in this lecture, we will talk about what are the ocular emergencies and what are the trauma, and we will talk about how we can identify how they present and what we can do in an emergency situation. First, we should know the red flags. Red flags means so the symptoms uh, which will trigger us to go and act immediately. So first one is sudden and severe eye pain. So the people will get sharp, intense pain in the eye, particularly if accompanied by the headache or nausea. Those could signal conditions such as acute angle closure glaucoma or orbital trauma. The second one is sudden vision changes. So the patient will come and tell there's a rapid onset of blurred vision or loss of vision, or the appearance of flashing lights, which we call the flashes or floaters, may indicate some serious conditions like retinal detachment, central retinal artery occlusion, any kind of trauma. So those things. Third one is eye redness and irritation. When we are talking about the emergency department in the eye section, so the most people will come with the eye redness and irritation. From those, we need to identify who need attention first. So if there's a persistent redness, tearing, foreign body sensation in the eye, especially following exposure to chemical or trauma, that can indicate chemical burns, corneal abrasions, infections, ulcers, endophthalmitis, or like that serious conditions. In those kind of situation, we need to act quickly. The other one is the visual field disturbances. So partial or complete loss of vision in specific area of the visual field described as curtain-like shadow or dark spots may suggest conditions like retinal detachment and vascular occlusions. Those people we need to identify quickly. The other thing is systemic symptoms such as headache, fever, jaw pain, scalp tenderness, and Those kind of symptoms may raise suspicion for systemic condition like giant cell arteritis, which can vision threatening complication if left untreated. So those red flag signs are very important to identify the patient we need to attend, and so we can attend quickly. If we categorize ocular emergencies and trauma, so we can categorize into several compartments. So one is the physical injuries. Physical injuries can be blunt trauma, penetrating and perforating injuries, and corneal foreign bodies kind of things. The other one is the chemical injuries. So exposure to chemicals and chemical burns to the eyes, either acids or alkali. So infection. Infections can be either corneal ulcers or the endophthalmitis. Painless sudden loss of vision. So it can be due to retinal detachment, central and branch arterial occlusions, and giant cell arteritis. Other things like close angle glaucoma and painful third nerve palsy. First, we will discuss about the physical injuries, basically the blunt trauma. So most of the time to the eye casualty, a lot of people will come with a blunt trauma. So, and we need to identify what are the features they have and when we need to attend and when we need to treat quickly. When we talk about the definition, blunt trauma refers to injuries caused by a blow to the eye or surrounding structure without breaking the skin. So there's no breaking in the skin, but there's a trauma. Signs and symptoms. Mainly there can be swelling and bruising around the eyes, pain and tenderness, and vision changes or vision loss. Common manifestation we can see in a blunt trauma, including periorbital hematoma. So there's a hematoma around the eye and surrounding structures, orbital fractures, subconjunctival hemorrhages, traumatic hyphema, iris damage or recession of angle, traumatic uveitis, and the more serious condition is the traumatic optic neuropathy. So we'll consider each. When we talk about the periorbital hematoma, so the definition refers to the accumulation of blood in the tissues around the eye following blunt trauma. The main signs and symptoms are, like in the picture, swelling and discoloration around the eye and maybe tender to touch. And there can be discomfort or pain with eye movement because of the swelling. And there can be visual disturbances. And visual disturbances can be due to because of the swelling and chemosis, there can be pressure on the eye globe, or else there can be the epithelial defects in the cornea as well. So what are the treatment options we have? So treatment options, call compressors to reduce the swelling. So because there's a bleeding, so you get the periorbital hematoma. Because of that, what we need to do is call compress. So it will stop the bleeding, and it will give a little bit of comfort, as well as it can reduce a little bit of swelling as well. And the same times, because of the tenderness and the pain, so we need to do the pain management. We can start simple painkillers like paracetamol or NSAIDs. And we don't need to do anything for the periorbital hematoma because it will automatically absorb into the tissues. Because of that, basically what we are doing is we are observe for spontaneous resolution. If we suspecting any infection, or if there's a large painful hematomas, we can drain and we can start antibiotics. The orbital fractures. Orbital fractures definition. Orbital fractures involve fractures surrounding bones in the eye, including the orbital walls or orbital rib. So the more fragile wall is the orbital floor, and there can be fractures in the medial wall as well. So the most fragile wall is the orbital floor. Because of that, in a blunt trauma, we mostly see the orbital floor fractures or blowout fractures. So in the picture, the X-ray shows the CT scan shows the orbital floor fracture in the left eye. So it gave away the flow, and the contents and the blood filled in the maxillary sinus. So basically, signs and symptoms: the periorbital swelling and bruising, which we call the ecchymosis, and restricted eye movements. Because the most common fracture is the floor fracture, so the inferior rectus muscle can be trapped in the fractured bones. Because of that, the mainly upward movements can be restricted. If there's any other fractures and any other muscles involved, so there can be other limitations as well. But the most common fracture is the floor fracture, and the restricted eye movement will be the upward eye movement will be restricted because of the inferior rectus and inferior oblique will be trapped in the fractured bones. Other one is the inophthalmos, sunken appearance of the eye, because now the flow is not supporting the eye. It can be, the content can be a little bit goes downwards, which we call the inophthalmos. And because of the eye movements are restricted, so they can get the double vision, which we call the diplopia. So the treatment, so small non-displaced structures, if the eye movements are normal, so we can observe. So we don't need to do anything, so it will heal by its own. So if they are not complaining double vision, and eye movements are not restricted, and if the fractures are small, so we can wait. So if the fractures are large and the inophthalmos is there and the double vision is there, so then we need to go for the orbital reconstruction and stabilization surgery. So in that case, we gonna repair the flow and replace the contents in the correct positions, and it will eventually reduce the double vision and the other problems. And the same times, we need to do the pain management. We need to start the painkillers, NSAIDs or the paracetamol, and we need to start antibiotics to prevent infection. Because in the blowout fracture and the floor fracture, so it will open into the maxillary sinus. So from the maxillary sinus, the infections can go to the orbit as well. Because of that, we need to cover with the antibiotic cover. Other one is a subconjunctival hemorrhage. Definition: subconjunctival hemorrhage is the accumulation of blood beneath the conjunctiva, the clear membrane covering the white part of the eye. So in the eye, there are three basically anterior eye. So first part we encounter is the conjunctiva. So then you have the tenon, then the sclera, which gives the white appearance. White appearance. So in this case, in any trauma, because the blood vessels are mainly in the conjunctival space, and the sclera, conjunctiva, and the tenons. So whenever the trauma is happen, and so the blood vessels get damaged, so you can get the hemorrhage beneath the conjunctiva, which we call the subconjunctival hemorrhage. When we're talking about the signs and symptoms, one is the redness in the white part of the eye in the conjunctiva, blood visible beneath the conjunctiva, usually appearing as a bright red patch. Typically painless and does not affect the vision. So whenever you have a subconjunctival hemorrhage, so it will not affect your vision. Because of that, we don't need to worry that much. And it can be associated with history of trauma or sudden increase of intraocular pressure. So the treatment observation, it will as the periorbital hematoma. So we will observe for spontaneous resolution. And if there's, because of the swelling, if there's a discomfort, we can use artificial tears to relieve the discomfort. And we need to educate avoidance of trauma or activities that may increase intraocular pressure. So other one is the iris sphincter damage. So iris sphincter damage involves injury to the muscles of the iris. The iris has sphincters and the dilator muscles, often resulting from blunt trauma or penetrating injuries. If the sphincter muscles get damaged, so you can get the uh, irido traumatic mydriasis. In here, so you can see the irregular shape dilated pupil, because pupil, it can constrict with the sphincter pupillae muscles. When it get damaged, so you will get dilated pupil. And same as because of the trauma, because of the muscles damage, so you can get the irregular pupil. The same time you can get the photophobia due to increased light sensitivity, because now the pupil is large. I mean, earlier the sphincter pupillary muscles are working in the light, pupils will constrict and reduce the light entry into the eye. But in this condition, so because the sphincter pupillary muscles are damaged, so it can't work. So because of that, the pupil will not constrict in the light. So the more light will enter to the eyeball, and it will cause more glare and photophobia. And because of the same reason, you can get the blurred and distorted vision. So if the the sphincter pupillary muscle damage is more, so you can get risk of traumatic mydriasis, which we call the persistent dilatation of the pupil. So it will cause more problem in the future because of the glare and the blurred vision. In minor cases, we can observe for spontaneous recovery. So in major cases, and if there's a cosmetically significant effect or more photophobia and blurred vision, we need to go for surgical repair. Cycloplegic agents will reduce the pain and prevent syncope formation. If there's inflammation and pain because of the spasms of the ciliary muscles, so which we can reduce the pain and syncope formation by using cycloplegic agents like tropicamide or cyclopentolate. We are not using atropine, as those are long lasting cycloplegic agents. So other one is angle recession and iridodialysis. Definition: angle recession is a separation of the ciliary body from the scleral spur, usually occurring after blunt trauma, and can lead to glaucoma. So angle recession means, so angle is It's between the cornea and the iris. So there's an angle uh, in between the cornea and the iris, where the iris root attaches to the scleral spur. So there's a attachment in the iris is in 360 degrees attached to the sclera in the angle, which we call, there's a trabecular meshwork which drain the fluid out from the eye as well. So in blunt trauma, because of the traumatic effect, so this iris root can recess from the scleral spur, so which we call the angle recession, or else it can completely separate, which we call the iridodialysis. So in the first picture, you can see the angle recession. So the upper dark margin where the iris attached initially, and because of the trauma, it moves downwards, which we call the angle recession. So the attachment moves downwards. And the last picture, you can see the iridodialysis, which separates the iris fully from the sclera. When we talk about the signs and symptoms, initially those patients are asymptomatic, but later it can lead to chronic open angle glaucoma. So in the glaucoma, so we can see the increased cup to disc ratio, elevated intraocular pressure, and same time we can see the visual field defects and peripheral vision loss. And in the iridodialysis, the 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 other part of the iris detached from the sclera act as a second pupil, and they can get the photophobia and as well as the blurred vision as well, because of more light entry into the eye, as they are having two holes uh, which enters the light into the eye. So the treatment, because initially they are asymptomatic, we have to observe and regularly follow up with monitoring intraocular pressure and glaucoma. If there's a increase in intraocular pressure, we can start the topical medications like beta blockers and prostaglandin analog to lower the intraocular pressure. If still with the medical treatment, if the pressures are high, so we can go for the laser trabeculoplasty or surgical management for IOP reduction. And same time, if there's a large iridodialysis, we can surgically repair as well if there's a persistent blurring vision or glare or photophobia is there. Other one is a traumatic hyphema. Traumatic hyphema is the accumulation of blood in the anterior chamber of the eye following blunt trauma. So in the picture, you can see the blood margin, blood level, so which you call the hyphema. So it can be partial hyphema or the total hyphema. So if the antechamber is completely filled with the blood, which you call the complete hyphema or 8-ball hyphema. And so these are partial hyphemas. So we need to identify the hyphema, and so we need to treat them. So basically, we can see the visible blood in the anterior chamber, typically layered at the bottom due to the gravity. They can get decreased vision and blurred or hazy vision because of the blood in the anterior chamber, and you can get the inflammation, and the same time the intraocular pressure can be rise. So because of those reasons, you can get the blurred vision and the pain as well. Eye pain, especially with the eye movements, increase intraocular pressure, So if it persists for so long, so it can lead to optic nerve damage and lead into glaucoma as well. So treatment options, because of the trauma, they get the bleeding. Because of that, we need to bed rest and uh, head elevation to reduce the intraocular pressure, because it will gravitate downwards and it will help to reduce the inflammation as well as the intraocular pressure. And same time, we need to start the topical corticosteroids to reduce the inflammation. And the some starts cyclopedic agents, but some don't. The cyclopedic agents will reduce the ciliary muscle spasms, and that will relieve the pain and prevent synaptic formation. But the other problem is if there's a trauma and if there's a bleeding area, so because of the iris contraction and the dilatation, it can lead to further bleeding as well. Because of that, the some may start the cyclopedic stance, some may not. We need to strict activity restriction to prevent rebleeding. The basically we do not evacuate blood initially. So we start the steroids and anti-glaucoma agents and sometimes cyclopedic agents, and we will wait till spontaneous reabsorption. And if rebleeding is there, and so if the pressures are high or the persistent uh, high FEMA, so we might need to go in and evacuate the blood. So otherwise, we will wait till spontaneous resolution. Other one is the traumatic uveitis. The traumatic uveitis is inflammation of the uveal tract, iris, ciliary body, and choroid following blunt trauma to the eye. The major signs are eye pain and discomfort because of anterior chamber cells are there, so they can get the photophobia due to light sensitivity, and redness and inflammation of the eye. So you will get the conjunctival injection, the mainly around the cornea, so which you call the circumciliary injection or circumcorneal injection. So it won't injected all eye, I mean the all sclera. So but the around the cornea. The same times they can get the blurred vision as well. So treatment wise, we need to start topical corticosteroids, prednisolone or dexamethasone, to reduce the inflammation. And if they complain pain due to ciliary muscle spasms, we can start the cyclopedic agents, which will relieve the ciliary muscle spasms and reduce the pain, as well as it will prevent synaptic formation. So in these conditions, so we use short-acting cyclopedic agents like tropicamide or cyclopentlate. Cyclopentlate is a not the short action. It's a mid action cyclopedic agent. Tropicamide is a short acting cyclopedic agent. The same times we can use antibiotics if infection is suspected. Most of the time there's no infection, there's only the inflammation. So because of that, with the topical corticosteroids and the cyclopedic agents, we can manage the traumatic uveitis. So the most serious condition is the traumatic optic neuropathy. So because that if the traumatic optic neuropathy happen, so there's no reversal. Traumatic optic neuropathy is damage to the optic nerve, often resulting from blunt trauma to the head or the orbit. The major signs are visual disturbance, that sudden vision loss or blurriness, and peripheral vision may be affected. Color vision is affected and they can't distinguishing colors. And the same times they can get pain, headache, or diplopia that may be due to effects of trauma. Research evidence shows, survey of 100 patients showed that 80% have the 80% of patients have optic neuropathy have the blunt. When we're talking about the causes of traumatic optic neuropathy, blunt trauma is the commonest cause, includes sports injuries, falls, and assaults. The other one is the penetrating injuries, gunshot wounds, or knife injuries directly affecting the orbit. Surgical complication can cause optic neuropathy as well, traumatic optic neuropathy as well. And study found that blunt trauma account for 60% of cases of optic neuropathy. So in the optic neuropathy, so this is the picture showing normal optic nerve. And when you have optic atrophy, so you will get a pale kind of disc with no clear margins. So you can clearly identify from the right picture to the left one. So the right one is more yellowish color optic nerve. So the left one, more pale optic nerve, which shows the optic atrophy. When you are talking about the management of optic neuropathy, first, we need to stabilize the patient and assess the injuries. Within first 72 hours, we may consider starting high-dose corticosteroid that supposed to reduce the inflammation, but there's no clear scientific evidence. So within 72 hours, if we start corticosteroid, high-dose corticosteroid, methylprednisolone 1 gram injection, so it will recover the vision. So because of that, and the same times we need to assess the patient condition first, because if the traumatic optic neuropathy associated with the head trauma, we not we do not start high dose methylprednisolone, because it can aggravate the brain traumatic conditions, so and eventually can lead to death as well. Because of that, we need to the identify and stabilize the patient first, and then we can think about starting the high dose corticosteroids. Some centers, so they have tried the optic nerve decompression in selected cases as well, but no clear evidence that if we do optic nerve decompression, we can revert back the vision. Because most of the time, if the traumatic optic neuropathy is there, so the patient will lose most of their vision. Because of that, rehabilitation is more important, and we need to counsel the patient for vision loss, and so we need to think about visual rehabilitation as well. The prognosis and outcomes. The factors influencing prognosis is type and severity of the injury and time to treatment. Statistical outcome, 20 to 40% of patients regain some vision post-treatment. So they won't get the vision fully, but they can get some kind of vision after the treatment. Long-term follow-up, importance of regular monitoring of changes. So if there's a traumatic optic neuropathy, so we need to monitor them because now this eye vision is lost and we need to care about the other eye as well. And the same times we need to monitor for other changes if some kind of vision is there. So the first we talk about the blunt trauma, and now we'll move into the physical injuries. The physical injuries, there can, I mean, in the eye casualty, so the half of the patient will get blunt traumas, the other half will get basically the physical injuries, the penetrating and perforating injuries. Penetrating injuries involve foreign objects entering the eye, while perforating injuries involve object passing completely through the eye, either the partially or completely through the eye. So the foreign objects will go. Signs and symptoms. So it can visibly entry wound, severe pain, and profuse tearing and bleeding, and the same time loss of vision. Treatment, depending on the injury. First, we need to stabilize the patient and protection of the eye. And depending on the condition, we need to act accordingly to repair the wound. So it can be either corneal laceration or scleral laceration or corneoscleral laceration. So foreign bodies may be inside the eye. So because of each condition, we need to think about what we need to do, and so accordingly we act. So if there's a projectile injury, we need to think about the intraocular foreign bodies as well. So because of that, any projectile injury, if the corneal laceration is there, and if we can't foreign bodies outside the eye or in the anterior chamber, so we need to do either, if there's a metal foreign body, if we are suspecting a metal foreign body, we need to do a X-ray. And if we are suspecting the wood or some uh, wood, plastic, or some other kind of foreign bodies, we need to go for a CT scan. So if we are suspecting metal foreign bodies, we do not do MRI scans. So for the other foreign bodies, so we can do a MRI scan as well. But the basically what we are doing is the CT scan to explore the intraocular foreign bodies. And the same times we need to start antibiotics to prevent infection, the topical antibiotics as well as the intravenous antibiotics. So the same times we are starting oral ciprofloxacin as well, because the ciprofloxacin has the most penetrative effect to the eye, because the other antibiotics will not cross the blood-brain barrier more effectively. Uh, blood barrier more effectively and enter to the eye. So it will basically give cover to the surrounding structures, but inside the eye, the ciprofloxacin will be available most. Because of that, we are starting either oral ciprofloxacin or oral moxifloxacin. The the most commonly seen physical injury will be corneal foreign bodies. Um, So the foreign objects that become lodged in the cornea, causing irritation and potential injury. Signs and symptoms: foreign body sensation in the eye, pain and discomfort, redness and tearing. So the treatment is removal of foreign body, and we can start the topical antibiotics to prevent infection. And so the other major condition which we encounter in eye casualty is the chemical injuries or chemical burns. That can be due to exposure the eye to chemical substances like acids, alkali, or other solvents. Severity depends on type of chemical and duration of the exposure. Basically, they will come with the pain, redness, tearing, and swelling. And they will have the visual symptoms like blurred vision, photophobia, and potential visual loss. When we are examining the eye, so the conjunctiva can be hyperemic, corneal opacification can be there, and possible perforation also can be there. Studies showed that 70% of patients reported severe pain immediately following exposure. So once we see the patient, we need to categorize the degree of the chemical injury. So this is Roper Hall classification. So there's a two couple of classification methods. One is a Roper Hall, one is a Duas classification, which is a more descriptive classification. This is a more simpler form of classification, the Roper Hall classification. So you can see there's a 4 grades. Grade 1, so you will get the clear cornea. There's no limbal ischemia. So the prognosis will be excellent. So grade 2, cornea will be hazy, but the iris details are visible. So hazy cornea, but iris details are visible. There can be limbal ischemia. 1/3 of limbus can be ischemic. So which we call a grade 2, and it also has a good prognosis. Grade 3, the hazy cornea, and the same times no iris. We can't see any iris details. 1/3 to half limbal ischemia will be there, and the prognosis is guarded. That means it can go into good way or the bad way as well, because of which we call the guarded prognosis. Grade 4, the complete opaque cornea, the more than half limbal ischemia, the prognosis is very, very poor. So that means intraocular involvement is there. The prognosis of acid or alkali burn, mainly the most types of burn we get is the acid as well as the alkaline burns due to the lime. The factors affecting prognosis: type of liquid, acid or alkali, concentration, duration of exposure, and how quickly we treat it. So those are the factors affecting for prognosis. General prognosis: mild cases often recover fully. Severe cases may lead to complication like glaucoma or blindness. The statistics shows up to 50% of severe cases may require surgical intervention. So when we get a patient with acid or alkali exposure, first what we need to do is rinse eye immediately with a copious amount of water or saline. Avoid rubbing and apply pressure to the eye. If there's a contact lens present, we need to remove the contact lens immediately. So this is the protocol we can follow in eye casualty unit with a patient with acid or alkali exposure. First, we need to get a good history from patients and the bystanders who comes with the patients, and the nature of the chemical, and what kind of accident, how long the exposed, and as well as what are the immediate things they have done, so whether they have irrigate quickly. So those things we need to ask from the patient and the escorts. And we need to check the vital signs as well to exclude inhalation or ingestion of the chemical. And because of if there's the ingestion of the acid or alkali, so it can cause laryngeal edema and can be lead to more serious conditions. Because of that, we need to check the vital signs as well. And the same time, if we have the pH strips, we can test the pH in both eyes. Then we can instill anesthetic drops, commence with wash with saline or running tap water. Use speculum to keep eye open. Look for and remove obvious particulate matter. If there's a lime exposure, so we need to double liver and see whether there's any lime particles behind the upper lid. And if there's the particles, we need to remove. We need to double liver and remove any particles, and we can irrigate. And wash continuous for 15 minutes and wait for 5 minutes. And if we have pH papers, we can check the pH, and we need to irrigate until the neutral pH level is achieved. So at least we can irrigate more than 30 minutes. In clinical assessment, we need to see the cornea and the conjunctiva and the limbus to classify what grade it is, and we can use the fluorescein stain to see the epithelial defects. So classify and grade with the classification, either Duas or the Roper Hall. And we need to check lid, conjunctiva, limbus, cornea, anterior chamber, iris, pupil, lens, and intraocular pressure, and if fundus is visible, fundus aspect. Then we need to start the medical treatment immediately. Preservative-free options if available. We can start antibiotics as prophylaxis. Anti-inflammatory agents like prednisolone or dexamethasone. Cyclopentolate or atropine to reduce the pain due to ciliary muscle spasms. And we can start sodium citrate 10% if available, and oral vitamin C 1 gram 4 times a day, and oral acetazolamide or any other topical anti-glaucoma agent to reduce the pressure, and oral doxycycline or the tetracycline. Interventions. So if we suspecting infections, so we can send swabs culture. And if there's a limbal ischemia and large epithelial defects, we need to go for surgical intervention as well. Sometimes we might need to do the tenon advancement as well as the amniotic membrane grafts. So the last slide, we talk about the specific treatment options. antibiotics, steroids, cyclopedic agents, artificial tears, ascorbic acid, tetracycline or doxycycline. The surgical treatment, so if there's a severe limbal ischemia, so we might need to go for amniotic membrane transplantation as well as the tenon advancement. And later, uh, because of the vascularization and also we might need to go for the limbal cell transplant. And if we can't get the good vision with the corneal transplant and all, so we might need to go for the Boston keratoprosthesis as well. So you can see Boston keratoprosthesis in the right hand picture. So in this kind of eye, I mean the left hand picture, you see the vascularized cornea with very hazy cornea. So we can't recover the vision with the corneal transplant on that kind of eye. So for that kind of eye, we can go for the Boston keratoprosthesis. The other one is the infection. So we can get the corneal ulcers. So it can be either due to bacterial, viral, or fungal. So the symptoms they can get is eye pain and discomfort, redness and inflammation, photophobia, and tearing. So treatment depending on the the suspicious agents, either bacterial, viral, or fungal. So depending on the suspicious agents, we start the treatment. Uh, we can use topical antibiotics, antifungal medications, or else if we are suspecting viral infections, we are starting antiviral agents like OCA cyclovir. So before starting treatment, some centers, if the lab facility is available, so we can scrape the corneal ulcer and send in a KOH slide. We can send for the culture and ABST as well, and after that we can start treatment immediately. Usually with the corneal ulcer, we are not patching the eye, but the some conditions, if the neuropathic ulcers and also we can patch the eye. Then we can go for specific management. So we can go for debridement and sometimes we can use the bandage contact lens, conjunctival flap, and the perforating corneal ulcers. We might need to go for the penetrating keratoplasty as well, corneal transplant as well. When we are talking about the infection, more serious infection is the endophthalmitis. Is a severe infection of the intraocular fluids, often occurring after intraocular surgery or trauma. And sometimes you can get mm, they can get severe eye pain, redness, vision loss, and you can see the hyperpain in the anterior chamber. Hyperpain means the pus collection in the anterior chamber. You can see the pus collection in the inferior part of the anterior chamber in the picture. So the treatment, mainly we need to treat for the causating agent. If the facility is available, so we can get the anterior chamber fluid or the vitreous fluid and send for PCR to identify the agent. But most of the time we don't have the facilities to identify the agent. Because of that, we need to start treatment immediately. So for that, we will start topical antibiotic as well as the intravenous antibiotic, preferably third generation cephalosporin, ceftriaxone or ceftazidime. Uh, as well as we need to start oral ciprofloxacin or moxifloxacin because it gives you more um, concentration available in the eye fluids, as well as we can give intravitreal vancomycin, or if you are suspecting fungal, So we can use amphotericin or any other voriconazole, amphotericin or any other fungal agents as well. So in early period, if it's not settling with the antibiotic therapy, so we can go for surgical intervention and do vitrectomy and remove the infected vitreous and continue the treatment. So other emergency we can get is a painless sudden loss of vision. The one condition that can cause painless sudden vision or loss of vision is retinal detachment. Retinal detachment occurs when the retina pulls away from the underlying tissue, leading to visual loss if left untreated. The main signs and symptoms: sudden onset floaters in the vision, and they can get the flashes as well. So that's why when the patient gets the flashes and floaters, we need to we can't postpone the patient seeing in the casualty. So we need to immediately dilate and see whether there's any retinal tears or retinal detachment. So they can get the blurred vision or curtain-like shadow across the visual field. That for the retinal detachment, the treatment is surgery. So we can do pneumatic retinopexy or fast paler vitrectomy with or without buckle, or we can use silicone oil as well. So in here, what we are doing is pneumatic retinopexy is, so if there's a the the tear is small and the retinal detachment is small, the macula is not affected, so we can use the pneumatic retinopexy. And so we will insert air bubble, uh, not the normal air. So there's a the specific kind of gas we are using uh, inside the vitreous, which will tamponade the retinal tear, and eventually retina will attach. In the pars plana vitrectomy, what we are doing is we go inside the eye and we remove the vitreous, and so we laser the tear, and for attachment, either we can use silicone oil or the bucket. The same times we can use only the retinal tear is there without retinal detachment. We can do the laser therapy or cryotherapy to seal the retinal tears. So other condition we can get painless sudden loss of vision is a central or branch arterial occlusion occur when the retinal artery is blocked. That can lead to sudden visual loss. Signs and symptoms: sudden painless vision loss. So when we are looking at the fundus, you can see the cherry red spot. So in the picture, you can see the cherry red spot in the center with the fovea. Because of the surrounding retina is pale, and you can see on that area, because of the retina is very thin in the foveal area, so you can see the choroid well through that area, that you call the cherry red spot. So in a branch retinal artery occlusion, you can get a sectoral vision loss. And in the fundal examination, you can get the optic nerve swelling as well. So you can see the optic nerve swelling in the picture. Treatment: immediate ocular massage or anterior chamber paracentesis. So that won't, I mean, that won't give 100% recovery. So, but we are doing ocular massage and the anterior chamber paracentesis to reduce the pain and increase the blood flow to the affected areas. The same times we can use the inhalation of carbogen, 90%, 5% oxygen and 5% carbon dioxide. The some centers, they do immediate surgery and try to remove the block. And some cases, there was some successful cases as well. So the basically there's a central or branch arterial occlusion. We need to think about the conditions that can cause blood clots. Because of that, we need to go ahead with the thorough examination uh, with including echocardiogram and the carotid duplex. Other condition you can get sudden loss of vision is a giant cell arteritis, mainly in the 50s or 60s. It's a systemic vasculitis affecting medium or large arteries, including temporal artery, that can lead to ischemic optic neuropathy and sudden visual loss. The signs and symptoms: headache, scalp tenderness, jaw claudication, and vision loss, particularly altitudinal or sectoral visual field defects they can get. So when we are examining, so they can get optic nerve edema, as well as because of it's a systemic vasculitis, so ESR and CRP can be high. So that's why when they get sudden visual loss, we are doing the ESR and CRP to see whether there's any suspicion for giant cell arteritis. Treatment, we need to admit the patient and start high-dose corticosteroid therapy, preferably methylprednisolone 1 gram daily for 3 days. And after that, we move on to oral corticosteroids with 1 milligram per kilogram body weight. And we can do temporal artery biopsy to confirm the diagnosis. So if you are suspecting giant cell arteritis, so the gold standard is a temporal artery biopsy to confirm the diagnosis. And we need to promptly refer to the rheumatologist for systemic management, because it's a systemic vasculitis, so it can affect other parts as well. Because of that, we need to refer to the rheumatologist to start the systemic management. So other emergencies we can get is a close angle glaucoma, angle closure glaucoma. When there's a sudden increase in intraocular pressure due to blocked or drainage angle of the eye. Signs and symptoms: severe eye pain, headache, blurred vision, halos around the light, nausea, vomiting, and mid-dilated pupil. So you can get the inflamed eye. Treatment. So we need to immediately reduce the intraocular pressure, either by starting, if available, we can use the intravenous acetazolamide. If not, we need to start oral acetazolamide as well as other anti-glaucoma topical agents. And the same time, we need to start steroid to reduce the inflammation. And once the pressure is, and we can use mannitol as well to reduce the intraocular pressure. Once the pressure settles and the inflammation settles, we can go for laser peripheral iridotomy, or else the iris is antechamber is very shallow, we can go for surgical iridotomy. So those are the basically the traumatic and emergency conditions mainly we see in the eye unit. So The key take-home message is we need to act fast and prioritize your side when it comes to ocular emergencies. First, we need to recognize the red flag we discussed, and such as sudden and severe eye pain, vision changes, eye redness, and systemic symptoms, and seek immediate medical attention if you experience any of these signs. And we need to remember early intervention can make a significant difference in preserving vision and preventing long-term complications. Whether it's a physical injury, chemical exposure, infection, or sudden vision loss, don't delay, and prompt care can save your sight. Because of that, we need to act fast and identify and immediately start the treatment to prevent long-term complication and preserve the vision of our patients. Thank you. Basically, that's the ocular emergencies and trauma we can see in our emergency departments mainly. Uh, do you have any questions or any clarification you need? Seems like don't have any questions. So shall we wind up then? Okay, thank you for participating for the lecture. And so there are more lectures lectures coming up in the future, the more interesting topics. So see you there in those lectures as well. So thanks for participating. Thank you all.